Good afternoon, everyone. Thank you for joining us on the Healthy Transitions educational webinar. My name is Kristen Paulson. I'm with the Center for Improving Value in Healthcare, and I'm happy to be with you today to talk about the role of palliative care in improving care transitions. There we go. Civic is the managing partner for Healthy Transitions Colorado, sponsoring campaign for this webinar. Healthy Transitions Colorado is a collaborative effort, and we're focused on aligning and accelerating the existing efforts to improve transitions of care across Colorado. We believe that by working together to break down the silos of healthcare, we can foster true community care coordination across facilities, specialties, and practices. We coordinate the tools, resources, and efforts of many partners across the state. We want to keep Coloradans healthy so they can enjoy more of what our beautiful state has to offer. Our goals for the campaign follow the triple aim. Over the next 2 years, we hope to eliminate 8,700 readmissions, eliminate 34,000 days in the hospital, and save over $80 million for Coloradans. If you haven't already done so, we'd like to invite you to become one of our community partners and take the pledge to improve patient care transitions. To take the pledge and learn more about Healthy Transitions Colorado, visit our website at www.healthytransitionscolorado.org. So just a couple of things before we get started.
The conference has been muted.
Everyone has been muted and will remain so throughout the webinar. We're going to be using the chat features available in the lower left-hand corner of your screen to field questions and allow you to make comments on the discussion. Questions posed will be answered during the question and answer session after the presentation. This webinar is being recorded and will be posted to the Healthy Transitions website in the next week or so you may access the information again at any time without cost. I'm now going to turn things over to Beth Ryan, the Director of Optio Health Services at the Denver Hospice. Beth?
Thank you very much. My task today was to present to you information on how palliative care can take a role in care transitions. And that's pretty exciting for me because we have been working in care transitions, advanced illness management, and palliative care for quite some time now, and we feel that these can be interchangeable in the delivery of care and create a seamless transition from care environment to care environment if the providers understand and know the availability of different services. So today's discussion, we're going to talk about defining how palliative care is distinguished from hospice, understand the broad spectrum of services available to patients receiving palliative care, and identify many of the benefits of palliative care provision for patients and caregivers. I wanted to start the presentation with discussing palliation, or what palliate means. It comes from a Latin word called pallium, and it means to cloak. It means to feel relief and ease by many different avenues and things that we can do. It's achieving a sense of control of oneself. It's having pain and other symptoms relieved. It's experiencing relief from psychosocial, emotional, and spiritual distress. It's recognizing the choices and identifying priorities for oneself. It's feeling support and validation for yourself and family, and it's understanding disease trajectory and prepare for disease progression. As you can see by the definition and the points that I've put on this slide, palliation means a lot of different things to a lot of different people. But the main thing that I want to emphasize is that it is an interdisciplinary approach to healthcare, and it can or may not involve many different professionals and disciplines. The next slide is the phases of palliative care, and I like this slide because when I first started in palliative care, it really helped me get a sense of the different places individuals may be at in the phase of their disease progression. So palliation, again, is to lessen the severity without cure, including symptom management, or to alleviate. As we talk about palliation, you will understand that palliation is indeed part of what hospice does, but it's a part of what hospice does, and palliative care can be part of what the patient or the individual receives as their health care is identified as a chronic need or an advanced illness and ongoing through their health care needs and up to and including hospice. So the phases of palliative care that I've outlined that were defined by the NHPCO are palliative active. And the importance with palliative care being patient-centered, we always look at the patient's goal in the different phases. So the first patient goal for palliative active is to prolong survival by arresting the disease process. The psycho-emotional goal for the individual is to fight. These are probably people who are initially diagnosed with a chronic disease. It's their initial response to, oh my goodness, how am I going to manage myself with this disease? And their internal goal is to really make it work and to fight. The second one is palliative symptomatic. The patient's goal for this is to receive treatment to manage the tumor or disease and get comfort. The psychosocial or psycho-emotional goal for this phase is to hope. This may be a little bit more of an advanced illness. I'm thinking someone who has a cancer and we're trying to manage the cancer through chemotherapy or radiation therapy. The next one, palliative supportive, is a patient goal to receive comfort and to prepare. Psycho-emotional goal is to surrender and accept. This is really a point where the patient or the individual is getting closer to the hospice phase and to end of life. By the time the individual gets to this phase of palliative care, they should have advanced care planning in place. They should have power of attorney in place. They should be ready for end of life. However, in our culture, that does not always happen. People are fighting and hoping for the best throughout their disease trajectory, and in fact, surrendering and accepting does not ever happen. The other piece of palliative care I wanted to just outline that really isn't part of palliative, but it is an important thing to remember, is that there is a piece that people are looking for to have cure. The patient's goal is to seek healing or to be healed or to eradicate the disease or tumor. And the psycho-emotional goal is to win. These are people that probably have some type of surgery they're facing, and they, of course, are going to have surgery, get out of the hospital, and go on with their life without any chronic disease or any effects of disease after.
Beth, we just had a question come in that I think might be a good one to address before we go further into the presentation. Could you talk a little bit about the difference between hospice and palliative care for those that aren't familiar?
Yes. Palliative care is a means of delivering symptom management, psychosocial, spiritual support, and defining what the patient's goals are much before hospice is much before the patient is prepared or ready to go to hospice. Hospice has been defined as end of life 6 months or less before death is expected. And in actuality, to go into a hospice care service, a physician has to make a note that that patient is indeed at end of life with 6 months or less to live and is indeed meets the qualifications for hospice. And it's a difficult thing to do. There's so many diseases that do not have a clear trajectory. Cancer maybe is more defined in the progression of that disease, but I think of the hospice teams that I work with, and dementia, our failure to thrive is very difficult to project, oh, this person is going to die within 6 months. And that is the fight of the hospice companies throughout the country, is to try to get our CMS, to understand that we don't have the magic bullet to say when that patient is going to die in some of these diseases. And it's very difficult for the patients and for their families, because they may have look like they're at within 6 months of death, and then all of a sudden they have a rebound and get better and gain weight, and then the hospice teams have to discharge, and it's a vicious cycle sometimes for care delivery.
Okay, thanks.
Mm-hmm. The next slide is showing the phase of disease and when chronic and curative care goes into effect, and what we're looking at for palliative care and when hospice is part of the patient's health care. And you can see on phase 4 that hospice eligible is truly at the end of life. I think that the difficulty with where our reimbursement is coming from is that, once again, CMS is trying to define that and make sure that we don't have our patients or individuals on hospice care too long, but that's a difficult thing to predict. So with the identification of a chronic or advanced illness, perhaps such as diabetes or congestive heart failure, COPD, you can see that in phase 1, the patient is relatively healthy and maybe even can have some reverse of the disease symptoms. But this is definitely chronic care. Some of it may be curative, some of it may be not. Also, then you move to phase 2, which is early onset of chronic conditions. This may be somebody who really is working and doing well on their day-to-day living, but still that chronic disease or advanced disease may be taking some toll on the individual. They may be having trouble with managing that illness in some respect. And then phase 3 is progressive. From a palliative care world, this is really when we would love to see our patient population start discussing and embracing more the thought of hospice and end of life. Unfortunately, our culture is not in that same path as we as healthcare providers are, and truly the palliative care services are patient-focused and what are their goals. So you can see that on the blue section through the graph, that palliative care can start as early as phase 1 when there is an identification of a healthy or some sort of illness. At that point, we want to start with advanced directive discussions. Yes, we should all have those in place, and yes, we should be prepared for unexpected events and for all of our lives. Then as we go through phase 2, 3, and 4, definitely we need to talk more about advanced care planning, and that's when the palliative care teams can really become effective in opening the discussions among families or with individuals about what does this disease look like and what might that bring for your care needs down the road, so those people can prepare a little bit for what might be in their future. I want to talk about the principles of palliative care a little bit, because I think these are words and things that we flip around in healthcare quite a bit these days. And it really is important to have an impact on what we're doing and to take responsibility for the care delivery that we are providing to people. So the first one I have is the patient's experience. One of the things that is very powerful in palliative care is that the clinicians are very respectful of the patient and family, their values and goals, and we empower them for their decision making. We try to relieve the caregiver burden. Some of my most powerful stories are the fact that our age group of people we serve in palliative care have gone from a population of over 65 greater than 50% to under 65 greater than 50%. And that means we're dealing with a lot of individuals who are ill, who may be trying to still keep a job. They have a family, they have children in high school. We may be having to integrate and trying to help the parents, the patient and the spouse or significant other to make sure that the children are taken care of and still engaging in school. It's really quite a difficult and individual experience for the patient, because it all depends on what their circle of family and what they are trying to achieve in life. The next one is quality. Provides focused care through a continuum of care settings, and outcomes are measured. I will tell you that in the quality component, and I'm just going to overview some of our outcome measures briefly. I don't have statistics and data because I don't think you guys all care about that. You probably more want to know what are the measurements we're using. So under quality, we measure such things as pain and anxiety management. We may manage how the patient perceives our ability to help them understand their medication regimen, how we respond to questions about their disease process, and then the outcomes measured for us include patient experience. Would they recommend our services to others? Do they feel like they receive value from what our services provided, and just what is the value to them? Now this again is all over the board, because to one person the value may be, I got to speak to the chaplain and I got to sort through my spiritual distress that I was having. And to another person it might be more physical symptoms. I had pain relief, thank you. So there's a variety of things we can focus on. If you talk to different palliative care people who do service in companies, you will find out that it's kind of all over the board right now. We're trying to distinguish standards of care. I believe it will be a regulated program at some time. So all those things are coming down the pike, but for today, we are kind of all over the board with the services that we provide. And that depends on the mission and philosophy of the company, kind of what their experience is and how invested truly the board and senior leadership is in the palliative care world. So the third one is choice then, and always, or cost, excuse me, and always we want to talk about the cost of patient's choice to maybe avoid hospitalizations, emergency room visits, or medications, tests, and procedures that they don't really want. I think of oncology at this time, and I'm not really pointing fingers at anybody, but oncologists and oncology clinics often are trying to help the patient seek healing or seek symptom management. And so sometimes the medications actually make that patient sicker than they don't have a quality of life. And maybe if the patient is educated and we can talk to the patient about, this is your choice. You can say no to this. Talk to your oncologist, and we can educate them and empower them to be able to go in and talk about that with their oncologist or even with their family. There's a lot of family dynamics in advanced illness management, depending on cultural implications and depending on spiritual, all those things. We walk that walk with the patient and make sure they understand that they have choice in what they're going to do. The difficulty in measuring, and I will talk about that with outcome measures, the difficulty we have to measure costs or financial pieces is that what we do really is a cost avoidance measure. For instance, we try to help people not go to the ER if they choose not to, or not to be hospitalized anymore for a primary diagnosis of like CHF, for instance. So we would say to them, you have a choice, and if you choose not to be in the hospital, that's your choice, but then we have to find a different arena of care. Maybe that is hospice, maybe they're not ready for that. So those are the things that we work on in palliative care. We do align in palliative care with triple aim, which I think is really important to talk about because that's the effort of healthcare. Improving quality of life through physical symptom management, and I've talked about this already. Pain, dyspnea, anxiety, depression, things like that. One of the things I have not mentioned too much is our social workers in palliative care are usually very experienced and capable of working with patients with a lot of anxiety and depression issues. And so we will either help them through that or connect them with a professional or another clinical expert who can help them really dig into that piece and what is causing the anxiety, what is causing the depression, and how can we help with that. We always respect the patient's goals and supports the individual's well-being. And that's not the well-being of the individual how we see it, it's how they see it. It's always important for us to keep centered on that person. We enhance the healthcare experience. One of the most important things in palliative care is to recognize that people do have a choice of where they want to receive their care, and that is one of the outcomes that are measured by some palliative care companies is the patients say, or the people say, we're getting care where we want to be taken care of. Usually that's in their home or in their assisted living or wherever they've been living for the past several years. Or for a younger family, maybe that means with their family, embedded, still having dinner together at the dinner table in the evening. Reducing and controlling costs, we've talked about that already. Acute care versus inpatient or in-home or outpatient care is definitely a cost factor. And then making choices about unwanted emergency and hospitalization visits. The next slide will show you the increase of health care spending, and it's highly concentrated. As you can see on the left side, there's a statement that says 1% subset of chronically ill clients account for 22% of healthcare expenditures. 5% of Medicare-covered lives drive up to 50% of the healthcare costs due to high hospitalization rates and costly treatment. One of the statistics also that I have in the back of my brain, I don't have a slide of it though, is that the cost of healthcare in the last, I think it's 2 years of life escalates. And I don't have the exact percentage of that, but maybe somebody out there does have that. But it's quite significant.
Close to 300%, I believe.
Yeah. So, yeah, and so it's pretty powerful. What I talk about with care transitions is anyone providing care transitions can intervene when you're seeing or you're experiencing people who are becoming more frail, having more emergency room visits, going to the hospital and saying, I don't want to do this anymore. Everybody, in my opinion, in healthcare needs to have that hat on and be willing to listen to those people and say, let's see what we can do for you. Let's see if we can make some connections with community services, home health companies, palliative care, hospices, anybody who can help even do telephonic discussion with that person and say, tell me about what's been happening and let's talk about what you want and where can we find help for you to get through this healthcare maze that we all will and do experience on a day-to-day basis. So I think it's really important that we put on that hat no matter what part of healthcare and where we deliver care. So just want to put that out there for everybody. Just think about that and really connect with that individual you're caring for or providing service for and listen to them, because that's the best cue and when maybe palliative care would be beneficial. So the next slide I have is a slide of where referrals come from, and you can see it's quite robust. We can get referrals from just about anywhere. Now there are different palliative care services provided, so just know from company to company, you probably, if you're interested in working with them, you probably need to spend some time with them and find out what exactly are you doing and how are you serving, and are you going into skilled nursing facilities and are you going into homes, because it's kind of all over the board again. So I'm not going to go through all these referral sources, but just know that referrals can come from anywhere. One of the best services we provide is to do education of people about palliative care and the opportunity that they may have if they're looking for palliative care for a patient or individual, and how we might be able to help them. So we do a lot of telephonic work with discharge planners and people just trying to sort through a specific care need or maybe more of a broad and general situation that they run into on a daily or more than once a year basis. We have many stories to tell about our referral sources, and the one thing I always say when we get referrals is we really do need the patient's primary care physician or whomever they are seeing on board with a palliative care referral and consult. And the reason is because we talk about advanced care planning. We talk about end of life. We talk about what are your goals, and we try to empower them if they are done with some sort of intervention. We try to help them sort through that and help them write down the points of what should they talk to their physician about. So if a physician is not aligned with palliative care or with end of life, I would caution anyone, and really it's an opportunity for maybe our liaisons or part of our team to go in and have a lunch with the physician and really talk about it. A physician's goals are to heal and keep people healthy, and so we're not all on that end-of-life page, and I think we have to respect that for the patient as well as the professionals. The next slide talks about enhancing the continuum of care, and I put in the circles the different environments that people will experience in the spectrum of life or could experience. We always think about, I think, palliative care in an inpatient setting. Oh yeah, it works in the hospital. Well, it's great in the hospital, but sometimes those patients are more in a at a disadvantage because they do not have time to really think about what are my goals. The doctor is saying, do you want to be intubated or not? And the patient and family are faced with that like today. So I say let's discuss and prepare people much earlier in their life and disease trajectory, especially if they have an advanced or chronic disease that's been diagnosed. So I think, the promise and the effort to have discussions in primary care physicians' offices is a wonderful endeavor, and I would say that is the best place, because I would definitely want to have that discussion with my primary care physician. Now, my primary care physician gave me, I think, a 5 wishes form and said, here, take this. So she had done her duty, and so that's good. I mean, at least there's an effort there, I think. And I'm relatively young and healthy, so, and I have it on my desk at home waiting to be filled out. So the in-home care, usually assisted independent living environments or in a home or apartment. In these environments, I think there's a number of ways to involve palliative care, and some of it may be pretty robust and some may not be. In a private home, we could do home health care, palliative care. I know there's a lot of companies that are integrating palliative care into their home health model. It's quite regulated, and we actually at Optio have a home health model that we partner with the HMO to provide. It's very successful. It's very robust. Our patients love it. They're usually quite ill, and they're probably within a year to 6 months of end of life. So they are pretty far on the trajectory of disease and end of life. Assisted and independent living, we also go into those environments, and I think there's rounding physicians and whatnot in those environments as well. The continuum of care, though, to me, is keeping a primary care physician engaged wherever you're at with that patient. And that could be the continuum, but also it could be a continuum within a company who provides different services of palliative care, such as a transition model to an advanced illness model to a true palliative care model. I mean, that care continuum would be ideal for a population who might be a certain diagnosis, congestive heart failure, COPD, or something like that. And then the outpatient setting, emergency department, of course, that again is a setting where you're kind of faced with needing to make a decision. That's a tough place to be, but they do, and I know that there are palliative care companies that are beginning to service in emergency departments. And then dialysis centers and infusion centers. I always think about dialysis centers because in one of our services, or 2 of them, we don't really integrate much with people with end-stage renal disease. And our philosophy with that is that we don't want to embark on changing orders for those specialists and those people who see this population 3 times a week in their center. For us to try to do symptom management and go into the home with a nurse practitioner could really muddy the water for those people receiving dialysis 3 times a week. Also, I think the dialysis centers a lot of times have social workers on staff, and they get to really know these patients. And so I think that in an ideal world would be a great environment to have those discussions. On the other hand of that, though, is the dialysis staff are really trying to help the patient to get them through their dialysis treatment. They're trying to keep them stable with their disease. So sometimes we've had calls from dialysis centers and just saying, we really need a social worker to go in the home and discuss advanced care planning and what this disease progression will look like for them so they can start thinking about end of life, basically. So we do that on occasion, and we do want to meet the patient's needs. So we would do that and make sure and then communicate back with them what the outcome of our visit was. So the opportunities continue to engage the patient to receive the best possible health care and feel the best possible health, to include a wider range of service with advanced illness, transitions of care, and other post-acute health care, and also to recognize inpatient care is really important. To eliminate gaps in care and seamless care with care transitions, advanced illness, and palliative care. Improve concordance of care with the patient's wishes. Tighten coordination with the primary care physician and other care providers. When we work with insurance partners, it's quite interesting because sometimes the primary care physicians are under contract with the provider, and sometimes they are not. So it's kind of a difficult world for insurance providers to really get the primary care physicians always engaged in what the provider's case manager or whomever needs to really accomplish A, B, and C. So that's a problem area, I think, that we've identified with different partners we work with. But then again, to make sure the patient and the primary care physician are aligned in the patient's wishes, and the doctor or the physician knows this patient wants A, B, and C, but not D. And then prepare for the disease trajectory. The sooner the better for that. I know none of us want to think about that if we have an illness we're facing, but it's really important. So the different care delivery models that I've outlined are three, and palliative care, again, all over the board. So some palliative care services are more consultative. It means that they get an order for a professional for advice or opinions or recommendations. Often that professional will sit and talk with the patient and family about their illness, the psychosocial piece, the spiritual piece. We utilize board certified and credentialed physicians for this in inpatient settings. Also nurse practitioners or certified nurse specialists may be involved in this. Also social workers are often involved in the consultative model. The referral model is where total patient care is delivered by the palliative care team. This is the model I mentioned in which we do home health palliative care. We take over the whole care environment, including chaplaincy and spiritual care, social work, RN, palliative care physician, certified nursing assistant. We absorb the whole care delivery for that individual. And then co-management, where we receive a referral, but still there's a group of clinicians delivering care, and we work concurrently to provide palliative care. My experience with that might be in a long-term acute care setting where they don't feel expert at doing advanced care planning, but we work with the clinical team in IDT and determine the best approach to have discussions with patients and or families. And the clinical expertise I talked about just a little bit, but I do want to emphasize a few other experts talking about the benefit specialist, who is really important to help people find payment, whether that means getting them on a Medicaid service or whatever, a navigator who can reach out and help the patient look at other care environments and talk about those. Some companies use volunteers, others use music and art therapy, bereavement. We use school counselors as part of the experts in providing care as well. I will tell you that our philosophy is to deliver the care with a concern that we do not want to bridge over into the hospice environment, and it's very expensive to provide all the services that everybody wants. So I would caution you, if you're looking at doing palliative care, to really look at the cost of that. And then I will also tell you that some companies think that music and art therapy are very important and will embrace that in palliative care. The next slide is kind of leaning into geriatrics and palliative care, and it shows you the different diseases and what that looks like in the trajectory and care of a geriatric population. Some of our diseases we treat are more successful in palliative care. They're the same ones as avoiding hospitalizations. Might be CHF, COPD, pneumonias, cancer, because we do a lot of advanced care planning with them. So those are the ones that we see and have more success with. The ones that we do not, because our program is not long-term, is diseases such as chronic pain or sometimes neuromuscular, where actually the neurologist and the neurology specialists, MS Society, ALS, and Parkinson's really can follow those patients long-term. So the last slide is our reality, and you can see that palliative care is not developed to the point where we really know where it's headed. It's not regulated. Care delivery models differ. We hope that people can understand and will be educated to know that palliative care is needed sooner. But the main thing for us in our reality is no one service provider can be successful in a silo. It takes many community resources, and we will continue to utilize community resources. And again, the future is that palliative care will become an insurance benefit along with whatever affordable care looks like in the future. We hope to be part of that. It must be in all health systems, at least we think so, but there needs to be standards of care and regulatory oversight. It's to manage advanced and serious illness, but it also needs to be recognized for sudden injury and life-threatening injuries that people are facing at a younger age, and that all people will be coached about their rights to make choices and engaged in a healthy lifestyle. I think I have finished my slides. I'm not going to go into a summary because we may have some questions.
We had some really great questions.
So let's open to questions.
First of all, thank you very much, Beth. This is a great presentation. For those on the line, these slides and the recording of this webinar will be posted on the healthytransitionscolorado.org website in the next week or so. So let's go ahead, and I'm going to start at the beginning with the first questions, and we'll just go through in order. So, wouldn't you want to have the MDPOA and advanced care plans in place way before the supportive phase? And could you tell us what MDPOA is for those who may not know?
MDPOA stands for Medical Durable Power of Attorney. It's a decision maker who is identified by the individual who can make decisions in case the patient themselves cannot. And of course, we would love to have it much sooner than a supportive phase. I think right now I look at reality, and the fact is that we're integrating it into a palliative care environment. I would love to see it at an earlier phase, and like I said, probably by a primary care physician when we first engage in our first visit, to have that discussion and at least to put it on the table for us, no matter what age, to start thinking about that and what that might look like. My thinking with that is, though, as I've gotten older and experienced life, my decisions might change. And so I think we always have to revisit that through the course of health and through the course once diagnosed with a disease. That might be different for me depending on what that looks like.
Great. Another comment, you mentioned that oftentimes it's difficult to determine a definitive 6-month projection, assuming to end of life for hospice qualification. But working for Medicaid, I believe there's some excessive pressure placed on the providers by themselves. Clients do not have expiration dates, and hospice's goal is to help a client get placed on services to receive the maximum benefit of hospice services. And it was just a comment.
Yeah, I respect that, and I would defer that to the provider for further discussion.
Providers are definitely a big part of
Yeah, absolutely.
Question from Mary Long, I suppose, Mari. What are typical health problems individuals have who might receive phase 1 palliative care, and what types of topics are typically addressed?
I'm probably thinking in phase 1 of somebody with a new diagnosis of cancer, breast cancer or cancer, and we don't know exactly where that disease is going, and that at that point there should be an introduction of this is an opportunity to help with symptom management and to discuss maybe an advance directive and have that in place and start thinking about that. The saddest part for me is we sometimes receive referrals on people who are actively dying and do not yet have or are not prepared with a plan. And that is a disadvantage for them and the people around them, whether family, significant others, whomever is their support system. It causes so much stress within the home.
I know you mentioned it a few times during the presentation, but you've said before that palliative care is appropriate for severe and life-limiting illnesses. It doesn't necessarily have to be both, but a severe illness, a severe diagnosis such as cancer that could go any direction would be an appropriate place for palliative care to start.
And I don't want to be like a Debbie Downer with that. I just want to emphasize that people have a right to know and understand. So that's the point I want to get across.
And there are many people who graduate from palliative care.
Correct.
Who, are cured and
correct.
Different. So, just a clarification of one of the issues we had earlier. 1/3 of all Medicare spending is on patients in the last 2 years of life, and 1/3 of that is on patients in the last 2 months of life.
Thank you, Jennifer.
Thank you, Jennifer. So, a question from Daniel Gray. How do you keep track of averting emergency room visits? Is that a patient reporting that without your help they would have gone to the ER, or do your clinicians determine when an ER visit was potentially averted?
That's a hard question.
So,
I can tell you a couple different approaches to that is we provide, in one of our services, we provide 24/7 support to palliative care patients. And if they call and we send out a nurse and work with a physician to have an intervention, then that's an aversion or a diversion from an ER visit or potential hospitalization. Sometimes those diversions, or sometimes the ER visit is related to the primary diagnosis, and sometimes it's not related. So that's the other piece that I think is really important to look at. If a patient has congestive heart failure and trips on on a step and falls and breaks their leg, that's really not something we would have impact on. But we might if they have congestive heart failure and are becoming weaker, and we've seen this weakness and they're having trouble negotiate stairs, and could we have intervened somewhere? So it gets kind of complex and convoluted if you dig too deep.
Well, and the fact that palliative care is a cost aversion service is challenging, especially in a fee-for-service environment where doctors are billed by service in many environments. That's starting to change. One of the things we do here at the APCD, or can do at the APCD, the All-Care Claims Database here at Civic, is compare those who didn't receive palliative care to those who did receive palliative care and look at overall ER usage. So it may not be on an individual basis, but we can compare average ER usage for those who did and did not receive palliative care and get an idea of the ER visits avoided that way.
So one of the other things for cost in hospices that have palliative care, many of the hospices look at when that patient is referred to hospice and the length of stay in hospice. That is not something that is publicly reported often because frankly, it might be a turnoff to the public to hear that, but it's reality in the healthcare environment of palliative and hospice care. So we do avoid costs actually by patients signing up and receiving hospice services, because then they do determine that they're not going to go back in the hospital or to the ER, although they always have that choice.
Right.
But, that's part of the hospice philosophy, to care for people in the home.
Another question from Kirsty Claverkamp. Do you need a physician order for palliative care in order for it to be covered by insurance? Is palliative care covered by Medicare and Medicaid?
The hospice benefit says that palliative care is a service that can be provided through as an extension kind of the hospice. But Medicare and Medicaid does not pay for palliative care per se as a benefit. What we receive payment for is for the nurse practitioner visits in one of our models as an extension of the primary care physician. So yes, you do need a physician's order for that, because that physician, whether a specialist or primary care, they need to be aware that we're in the home with the nurse practitioner and what we're doing, because they're really the responsible entity. In that care at home program, we cannot bill for social worker unless the patient has a specific behavioral health diagnosis and the social worker is recognized as a behavioral specialist, and I don't know all the details of that. And then the other services we provide, such as one of our programs, we provide very robust telephonic care. We don't get paid for that. Another program we do, home health, we do get paid for under the home health benefit, and then our partners pay us for chaplain services. So we get paid actually fee-for-service for that.
Just another reminder, thank you, Jennifer Valentine. Here in Colorado, we've actually just passed palliative care standards into the rules and regulations, the state rules and licensing regulations. Those are going to go into effect in March. We had a palliative care definition, a very specific definition that was adopted last year, and these standards are now going to be put into effect this year. And I believe we are the first state in the country to have this level of definition and standards put into the state rules and regulations. So congratulations for everyone on the phone that was involved in that, and congratulations to everyone in the palliative care world. That's going to make a big difference, I think, for us. So another question, can you talk a little bit about reimbursement for co-management and referral programs?
Reimbursement is really tough at this time, and I'll just lay that on the table. We do some partnering with insurance companies. We do some partnering with other providers, such as home health, things like that. And across the country, palliative care is getting covered within health systems. We don't, at least that I'm aware of, we don't have that in place. Many of our health systems and hospitals feel like they are managing palliative care internally with their own employees. We do provide consultation with a palliative care board-certified physicians within a couple hospitals in the area, but it's consultative, and we actually get paid by them for those.
Okay. Right. And then finally, could you just, I know you mentioned this at the beginning, but could you talk a little bit about what your demographics look like for your palliative care population? Is it just a breakdown, 65 and older, 85 older?
Yeah. 65 older is less than 50%. 65 younger is growing. 50 and younger is even growing more. Of that 50 and younger, cancer is prevalent. Our demographics for diagnosis that we really feel like we can manage in a palliative care environment is COPD, CHF and other cardiac, cancer, and in our palliative care, we do care for HIV and AIDS, and that came from a partner, an insurance partner who feels really strongly like that their population of people with HIV and AIDS disconnect from their primary care physician and do not receive services within primary care, and so they end up in the ER and in the hospital. So we service that population specifically because of that feedback. It's not a high number, but it is definitely a high need area for palliative care.
Great. Well, that's all the questions. Thank you again, Beth, for sharing your expertise today and really bringing some light to the subject. Thank you, everyone online, for joining us. We hope it's been a valuable use of your time. You've gained some information that you can use to further your care transition efforts. The webinar has been recorded, and it will be available on the Healthy Transitions website at www.healthytransitionscolorado.org within the next few days. Have a great day, everyone, and we will see you next month, where we'll be talking about health information exchange and care transition. Thank you.